Hi everyone. Thanks for coming and listening to the webinar. Obviously, this will also be the video will be posted on the website later. This is Avash, the course director, one of the hepatologists here at UC Health. I'd like to thank Dr. Forman, who's a professor of medicine and one of our experts in cholestatic liver disease in our section of hepatology here at University of Colorado. So, Dr. Forman, thanks for giving the talk today, and I'll turn it over to you.
All right, happy to. To remind everyone that there is a link for you to evaluate this talk. And thanks, Avash, for inviting me. I do see a lot of the autoimmune liver diseases here at the university, and so this topic is kind of near and dear to my heart. So first we'll start with PBC, and there's a lot of new data that has recently been released in terms of medications. So kind of an exciting time for cholestatic liver disease. So what is PBC? PBC is a chronic cholestatic disease, which has a progressive course. It's relatively rare, affecting 1 in 1,000 females over the age of 40. It tends to be more common among siblings and in families where one member has been affected, and it's thought to be due to a combination of both genetic predisposition and environmental triggers. A study done in Scandinavia showed that people who were exposed to hair dye, had frequent manicures, frequent UTIs, and lived near toxic waste dumps had a higher risk of developing PBC. Unlike PSC, PBC involves only the small intrahepatic bile ducts. And although the pathophys is not completely well elucidated, it does involve destruction of the biliary epithelial cells, which leads to cholestasis and buildup of toxic bile acids. To make the diagnosis of PBC, you need 2 out of the following 3 conditions. 1, you have evidence of cholestasis, primarily with an elevated alk phos. 2, a positive anti-mitochondrial antibody, or 3, histologic evidence of non-suppurative destructive cholangitis. In terms of labs, the ALT and AST tend to be elevated, but not that high. And then primarily you see an elevated alkaline phosphatase up to 10 times the upper limit of normal. The anti-mitochondrial antibody is most present, approximately 90 to 100% will have a positive AMA. But it's also important to know that you also can have autoimmune markers such as ANA and ASMA in up to 20 to 30% of patients as well. If one were to do a liver biopsy, which again is not necessary, you can see here on the left the well-formed granuloma. And then here on the right, this is kind of the classic findings that we learn about in med school, where you have a granuloma that is sitting right next to and destroying a bile duct. This is that florid duct lesion. The risk of liver failure and death increases as PBC progresses. Initially, there's this preclinical phase where patients are asymptomatic and might only have a positive AMA. And then eventually, patients will develop symptoms. And then without treatment, a significant portion will go on to develop decompensated liver disease with complications of cirrhosis. It's important to realize that males with PBC tend to have a worse prognosis with a higher non-response rate to ursodiol and a higher risk of liver cancers. Of the people that we have transplanted since I've been at the university with PBC that have had cancers, they all have been males. Also, non-Caucasians tend to have evidence of more severe disease as assessed by more refractory pruritus, more cirrhotic related complications, and higher labs. Whether or not this is true or just a bias in that non-Caucasians often are diagnosed late because people tend to think this as being kind of a white female disease, unclear. But again, non-Caucasians do tend to have more severe disease. So pruritus is extremely common in PBC. It occurs in at least 70% of patients. It tends to be diurnal, so worse symptoms at night, tends to be on the palms and the soles of the feet, and is exacerbated by contact with wool, heat, or pregnancy. The pathophysiology of pruritus is also not completely well elucidated. We think that potentially bile salts are acting as pruritogens. We know that endogenous opioids and the mu opioid receptors are involved, as well as serotonin receptors as well. There are increased levels of lysophosphatidylcholine acid and autotaxin activity, as well as activation of the itch neuron, which is the unmyelinated C fibers. In terms of treatment of pruritus, initially we tell patients to avoid the heat and wool, really use emollients, easier said than done, but really training to stop the cycle of itch, scratch, and itch. First line treatment is ursodiol, but I will say in my experience, I do not feel urso is that effective in treating pruritus. We then can use bile acid sequestrants with the caveat that you have to remember to tell the patients to take it either 3 hours or before or 3 hours after they take their other medications. If those other two things don't work, other options include rifampin at 150 to 300 milligrams daily. Remember that rifampin does have a lot of drug-drug interactions, and it is associated with DILI as well. Other things we can use are naltrexone at 50 to 100 milligrams per day, as well as sertraline. Studies clearly show that irrespective of changes in depression, sertraline can be very effective at 100 milligrams daily. And if that doesn't work, we move on to things like phenobarbital, plasmapheresis, and phototherapy. But even in the absence of cirrhosis, liver transplantation should still be considered in patients that have refractory pruritus. Fatigue is also very common in patients with PBC and has been associated with decreased quality of life. It's very difficult to treat. It's important to rule out things that you can fix, for example, such as sleep disorders, hypothyroidisms, and anemia. Important to tell people that they really should be exercising. Modafinil can be used, as can methotrexate, but I will say that I also never have used methotrexate in this indication. Patients with PBC also suffer from cholestasis and cirrhosis-associated complications. So irrespective of calcium and vitamin D levels, osteoporosis is accelerated. These patients have hyperlipidemia, but it's the non-atherogenic kind. Usually it's either elevated HDL, and if they have elevated LDL, usually it's lipoprotein X, which is non-atherogenic. But at exam, you might see xanthomas and xanthelasmas. Once they become cholestatic, they're at risk for developing fat-soluble vitamin deficiencies. And then patients can develop portal hypertension even in the absence of cirrhosis. HCC of all cirrhotic etiologies is relatively rare in patients with PBC. But again, as mentioned before, males with PBC do tend to have a higher risk of HCC. Moving on to actual treatments, I think we're all familiar with ursodiol. This has really been the backbone of therapy for PBC for the past 20 years. It's given weight-based and divided doses, 13 to 15 mg per kg per day. And it replaces the bile acids normally produced by the liver, which are more toxic and can harm the liver. Early treatment is much better. So once a patient has developed established cirrhosis, urso tends not to be as effective. And if you're going to see improvement, usually you see improvement in your liver test within the first couple of weeks of treatment, and 90% of the improvement occurs in the first 6 to 9 months. Urso is relatively safe. It may include clinical symptoms, and it has been shown to delay progression of disease and transplant-free survival, as well as improving quality of life. So this is a figure using the global PBC group, and you can see that those in the green that respond to urso have much better survival than those that do not respond to urso. Lately, however, we've been wondering whether or not we should be targeting for even a better alk-phos and better bilirubin levels. So this is looking at achieving a bilirubin that's less than or equal to 0.6, the upper limits of normal. And those people that do achieve that bilirubin is associated with decreased risk of liver transplant and decreased risk of death at 10 to 15 years compared to those that do not achieve that. So perhaps our treatment goals should definitely be even more rigid. The main problem with URSO, of course, is that 40% will not respond to URSO, and about 3 to 5% of patients do not tolerate URSO. So the next drug that was approved for the treatment of PBC is obeticholic acid, and this is a modified bile acid and FXR agonist. It has been shown to decrease fibrosis, decrease inflammation, and modify bile acid homeostasis by decreasing bile acid synthesis, decreasing bile acid uptake, and increasing bile acid secretions. The POISE study is a study that now came out almost 10 years ago. And this was a study where they randomized patients who were either intolerant to URSO or partial responders to URSO to obeticholic acid or placebo. The primary endpoint was a combination, either alk-phos less than 1.67 times the upper limit of normal or a bilirubin less than or equal to the upper limit of normal. You can see here the obeticholic acid arms are in the colored bars and placebo were in the clear bars. And those that took obeticholic acid, especially in the 10 milligrams, had a much higher response rate. And in the open label phase, this continued. So obeticholic acid was FDA approved. In terms of incidence of adverse events, I think the main one to be familiar with, and one of the main issues with this drug, is that in up to 60 to 70%, it is associated with pruritus, which again is not great in these patients who are itching to begin with. This is a study or two studies that basically looked at longer time on obeticholic acid. And you can see here that with using obeticholic acid for more than 5 years is associated with a 50% reversal in the amount of fibrosis, about 40% stabilization, 15% did have worsening. And then here on the right is looking at long-term patients on obeticholic acid. These are both databases from England, the global PBC database, and the UK PBC. And you can see in the blue here, those that were on the obeticholic acids did have a much higher incidence of survival. However, once we started using obeticholic acid, there were reports that people that had cirrhosis were decompensating. And so there's now a black box warning on obeticholic acid that in patients with decompensated cirrhosis or with compensated cirrhosis but evidence of portal hypertension, obeticholic acid is contraindicated. Please note, however, that in Europe, they do not have this contraindication. They do just recommend dose reducing. So that's all we had up until last month. And last month in June, elafibranor was FDA approved for the treatment of PBC in patients that either are non-responders, partial responders, or intolerant of URSO. So elafibranor is called Iqirvo. I'm not sure if I pronounced that right. And it's an oral dual PPR alpha and delta agonist. It is thought to decrease bile acid production, decrease inflammation, and increase bile acid metabolism and elimination. And in early phase 2 trials, it was well tolerated. It improved biochemical parameters and improved pruritus. So this is the study that is called the ELATIVE study. And again, they randomized patients that either had partial response or intolerance to URSO to 80 of oral elafibranor versus placebo. And then after that, there was an open label extension. And you can see here that those that were treated with elafibranor, 80 milligrams, had a 51% biochemical response compared to only 4% with placebo. And this response was defined a little bit differently than they defined it in the POISE study. This was a composite of an alk-phos less than 1.67, the upper limit of normal, with the reduction of greater than or equal to 15% of baseline, and a total bilirubin at or below the upper limit of normal. In addition, only people that were on elafibranor achieved complete normalization of their alk phos at 52. So a treatment benefit here of 15%. Looking at the alk phos, you can see that those that, again, were on the elafibranor as early as 4 weeks in, we start seeing that improvement and sustained alk phos decrease. Now, in terms of itching, in the early phase 2 studies, there was a trend for decreasing in pruritus. So we were very kind of excited about this. But in this randomized trial, the decrease in pruritus did not meet statistical significance. Although looking at the group that had the most severe pruritus, there did seem to be a more trend of having a decreased effect in lowering pruritus. But again, it did not reach statistical significance. Elafibranor was generally well tolerated. Again, pruritus is not one of its side effects. Most common side effects tend to be GI, some abdominal pain, diarrhea, nausea, and vomiting. This was the article that was published in the New England Journal that you can all look at the details about. And then last month at EASL, they actually released the open label efficacy results. So these are people that are on elafibranor at week 78. And you can see that their response is really sustained. So 70% had a composite biochemical response at week 78, and 19% had alk phos normalization. So this data seems to be very, very promising. So it was FDA approved, and so the indications are either in combination with URSO in those that are inadequately responders to URSO, or in those that do not tolerate URSO, monotherapy. It's 80 milligrams PO daily, and it can be taken with or without food. They do publish the following warnings and precautions. I believe in the study about 3 patients did develop either myalgias, myositis, myopathy, or rhabdomyolysis. Looking at these patients, however, these patients had other risk factors for having rhabdo. For example, I believe one of them was on statins, but just be mindful of this. There also were some fracture noticed in patients that were taking elafibranor. It's been associated also with hypersensitivity reactions as well as DILI. Right now, it is not recommended to be used in patients that have decompensated cirrhosis. It's to be avoided in biliary obstruction as well as in pregnancy. It is also a weak CYP3/4A inhibitor, and so there might be some drug adjustments that you have to make. So in addition to those 3 medications that we've discussed, if you look at the AASLD guidance, they in general recommend liver tests every 3 to 6 months, checking your TSH at least annually. I get a DEXA on our patients at time of diagnosis, and then every 2 to 4 years. Once they became jaundiced, then I usually will check their fat-soluble vitamins. And then definitely perform an upper endoscopy every 1 to 3 years if they have cirrhosis or the Mayo risk score is greater than 4.1. And in patients that do have advanced fibrosis, screen for HCC with ultrasound every 6 months. So we now have 3 drugs available to us, but there are still many, many studies looking at other medications for the treatment of PBC. There are other PPAR agonists being looked at. There are other FXR agonists being looked at, TGR5 agonist and PXR agonist. I'll spend a little bit time, however, talking about seladelpar because we think that seladelpar is going to be approved by the FDA in just a few weeks from now in mid-August. So seladelpar is a once daily oral PPAR delta agonist, and it has been shown to be important in bile acid homeostasis, decreasing fibrosis by decreasing stellate cell activation. It decreases inflammation, and it has other metabolic benefits such as decreasing cholesterol, decreasing LDL, and improving insulin sensitivity. So the first study that looked at seladelpar was called the ENHANCE study. And this study, similar to the elafibranor study, randomized patients that either were intolerant to urso or had inadequate response. And they were randomized either to placebo, 5 milligrams of seladelpar, or 10 milligrams of seladelpar. This study, however, was stopped early because of an erroneous safety signal in a concurrent NASH study. And so this study had to be terminated. And when they regrouped, excuse me, it was known as the response study. And again, the criteria was very similar to before in that they took people that either did not respond to URSO, partial responders, or were intolerant to URSO. And they were randomized now to either placebo or seladelpar 10 milligrams. And then after the response study in which people took either drug or placebo for 52 weeks, we now have a long-term study, which is called the ASSURE study. The primary outcome was that ALK Phos less than 1.67, plus the greater than or equal to 15% decrease in ALK Phos, plus the total bilirubin less than or equal to the upper limit of normal. Secondary outcomes included proportion of patients who had normalization of ALK Phos, as well as decrease in pruritus. So looking at the response rate at 12 months, you can see that those on seladelpar had a 62% response rate compared to 20%. So 6 out of 10 patients on seladelpar achieved the primary composite endpoint. And then only patients on seladelpar had complete ALK Phos normalization, and this occurred in about 25%. Looking at this graphically, you can see that placebo is here up in the gray, and this is ALK Phos less than 1.67 in the orange here. And you can see again, at 1 month, you start seeing that decrease in ALK Phos, which is persistent. Not really any difference, however, in bilirubin. Importantly, compared to elafibranor, in this study, there was a statistically significant improvement in pruritus. And it was more significant in those that had more severe pruritus to begin with. Even though it was statistically significant, I do also want to just draw your attention that it was not a huge response rate, but it did show statistical significance. And this, again, is the first drug that has been shown to really do this. Last month, Hepatology published an article really getting at why is seladelpar helping with pruritus. And so they actually were able to look at the patients that were in that first ENHANCE study that was terminated early. And they found that there was reduction in interleukin 31 with seladelpar. So this is the 10 milligram, the 5 milligrams, and placebo is in the gray. And not only that, serum IL-31 levels did correlate with pruritus. And so perhaps now we see that this is why seladelpar has impacted pruritus by decreasing the interleukin 31 levels. At EASL last month, they then actually were able to look at that rollover study, that ASSURE, and basically present their data that now have long-term outcomes of using of people that are on seladelpar for long-term. And you can see that patients that were on that long-term extension study for at least 2 years had up to a 95 or 94% composite biochemical response. And again, in the placebo, this was that response only 20%. And then in the legacy studies, basically they took patients that were on seladelpar in any particular type of study, you also got a 70% response rate. So patients on seladelpar achieved both a rapid and durable biochemical response rate. And then they also looked at pruritus, and we similarly are seeing a decrease that was statistically significant in pruritus. Now, this is also something that was not shown in any other study, but they looked at patients now that actually had cirrhosis. And in patients that had compensated cirrhosis, they showed that 65% had a composite biochemical response, and up to 24% of them actually had a sustained alk phos normalization. So even in patients that have cirrhosis can achieve a durable response on seladelpar. And so the authors really concluded that based on this long-term extension study, treatment with seladelpar led to meaningful improvements in markers of cholestasis up to 2 years, improved markers of liver injury. It was safe and well tolerated, and again, is potentially now an option for patients with compensated cirrhosis. So again, just in August, which is just a week or so away, it's expected to be FDA approved. I do not know anything more than that in terms of whether it's going to get an indication for cirrhosis or not, but we will see. There have been no head-to-head trials of ursodiol, obeticholic acid, seladelpar, and elfibranor. So I don't know in terms of how to choose one drug or another. I think at this point, potentially, if you have a patient that has significant pruritus, maybe seladelpar might be more of a benefit. It might, though, just kind of come down to what your insurance, what your patient's insurance is covering. So again, in August, there will be 4 drugs that are approved for the treatment of PBC. Other drugs, just to mention, that are on the horizon is bezafibrate. Bezafibrate is a pan-PPAR agonist. It has been known to lower lipids, but it also may improve hepatobiliary enzyme activity. It is not available, however, in the United States. But we have fenofibrate or Tricor, and I'll talk about that in a bit as well. So this trial that was published in the New England Journal that was called the BEZ-URSO trial. And this basically looked at patients that were on bezafibrate and URSO compared to those that were on URSO and placebo. And you can see that in the arm that was on the bezafibrate, that you had up to 31% having a response rate. Looking at labs, those were at bezafibrate had lowering of their alk phos, lowering of their bilirubin, as well as lowering of their ALT, and it also tended to improve liver stiffness as well. The Fitch study looked at fibrates for both PBC and PSC. So fibrates for each study. And overall, you can see that compared to placebo, patients that were on the bezafibrate had a higher reduction in pruritus, 45% compared to 11%. Looking just at the PBC patients, granted this is a small study sample, but 55% compared to only 13% in patients that were on placebo. It's important to know that the use of fibrates, however, can result in increased creatinine. This is a class effect. So if you look at the field study, which was a study not looking at patients with PBC, but looking at diabetes in patients with fenofibrate, there was an average elevation in creatinine about 12%. It's important to note, however, that this is reversible, and it's thought that this is not really representing a true decreased GFR, but it's basically inducing the metabolic production rate of creatinine. So even in patients that do have CKD, fibrates can be used safely. In the studies, however, it's been noted that fibrates can be associated with transient elevation in transaminases. I've had to stop personally 2 patients on fenofibrate when I started seeing a sustained elevation in the ALT and AST. There also have been case reports of acute hepatitis being reported, as well as chronic hepatitis with autoimmune features. This study is ongoing right now. We actually are a participant of this study, or we will be momentarily. And this was, again, data that were presented in EASL just last month. So this is a phase 2 double-blind study looking at obeticholic acid with bezafibrate. And so this was early 6-month results from the study, again, just presented 2 weeks ago or so. And you can see that those that were on obeticholic acid and bezafibrate did have a higher alk phos normalization compared to beza alone. And up to 66.7% achieved a biochemical remission in the combination group of obeticholic acid and bezafibrate. So we'll see what happens with this, and if bezafibrate does get approved, will it be approved with or without the obeticholic acid? Finally, before leaving PBC, I wanted to talk a little bit about itching. Maralixibat was approved a couple of years ago for the treatment of pruritus in pediatric cholestatic diseases such as Alagille's. So these are basically ileal bile acid transporters that lowers bile acid and has been associated in increasing transplant-free survival, increased quality of life, increasing or decreasing, I should say, growth retardation, and has been associated with decreased pruritus, decreased bilirubin, and decreased development of xanthomas. And so there's a study right now looking at not maralixibat, but volixibat, and it's a randomized trial looking at 20 milligrams twice daily compared to placebo for 20 weeks, and then followed with an open label extension up to 2 years. And in their interim analysis, there was a statistically significant improvement in pruritus. So you can see this right here. This is placebo compared to the volixibat. So we're still doing this study. We'll see what the end results look like, but this also might be a potential option for patients that have pruritus. Moving on to cholangiocarcinoma and PSC. 2 or 3 years ago, the AASLD did publish their practice guidance, and I encourage everyone to read this because it's the most updated guidance that we have on management of patients with PSC and cholangiocarcinoma. The pathogenesis of PSC is also quite complicated and not well elucidated. It's thought to really involve kind of 4 themes. The first one really involves the gut, where there is dysbiosis. The gut is leaky, and this in turn leads to immune activation by translocation of this bacteria. In addition, you get immune activation by aberrant tracking of lymphocytes, and this in turn leads to the cholestasis, and after you develop these biliary responses, you then get peribiliary myofibroblast activation, which then leads to fibrosis of the bile ducts. And because the pathogenesis of PSC is quite complex, it's been very difficult to find a drug that has been effective for the treatment of PSC. Looking at labs, very similar to those that have PBC, primarily we see an elevated alk phos. Bilirubin is usually normal, however, at diagnosis. The ALT and AST can be up to 3 times higher than normal. And the liver function test can normal and fluctuate during the course of patients with PSC. Of course, it's important to exclude not only other liver diseases, but also secondary causes of PSC or sclerosing cholangitis as well. Autoantibodies can be present up to 95% of particular anti-nuclear antibodies, anti-smooth muscle antibodies, p-ANCA, and IgG4, but the clinical significance is unclear. It may be an indicator of future development of overlap. To make the diagnosis, the standard of care right now is MRCP and not ERCP. MRCP is cost effective and accurate. It's non-invasive. Obviously, there's no radiation. It's important to note that ERCP does have better sensitivity for looking at subtle changes in the peripheral bile ducts. And obviously, the advantage of ERCP is that you can intervene on a stricture, where MRCP just gives you kind of a roadmap. But in a good quality MRCP, you really can see really incredible views of the entire biliary tree. If patients do have an episode of cholangitis and you think they need to have an intervention, the guidance still recommends that before going right to ERCP, perform an MRC. This again will allow us to determine if there's really any intravenous strictures and also can give a roadmap for our therapeutic endoscopy colleagues. We talked about what imaging looks like. You do not need a liver biopsy to make the diagnosis of PSC. And usually if you do a biopsy of patients with PSC, it's going to be normal because the large bile ducts are usually inflamed. And when you do a biopsy, you're usually only getting the peripheral bile ducts. However, if you do see a large bile duct, you can see this classic onion skinning fibrosis that we all learned about in med school. If you're worried about small duct PSC overlap not only with autoimmune hepatitis, but just with another disease, then a liver biopsy can be performed. But again, the way you make diagnosis is primarily with looking at cholangiograms. In terms of symptoms, fatigue, pruritus, and jaundice are most common, but up to 50% are actually asymptomatic at the time of diagnosis. And of those that are asymptomatic, about a quarter of them will go on to develop fatigue and pruritus when followed over 5 years. In a recent patient registry, 50% of patients will also report sleep disturbances, and this has been associated with impaired quality of life. Old studies looking at the prognosis of PSC show that universally it has a bad outcome and you will need a liver transplant. But these studies really were done at academic centers that were seeing the sickest of the sick. If you look at more recent population-based studies, you can see that compared to the liver transplant center studies, they tend to do much better. And so the patient survival here, you can see in the population studies, is much better than initially predicted. What we do know, though, that it is a progressive disease. The course is extremely variable, and there is no spontaneous resolution, and outcomes are not improved by colectomy for ulcerative colitis. You can look at the Mayo Risk Score or the Amsterdam-Oxford score. In clinic, you can kind of pull this up on your app if patients want to have a better idea of their short-term survival. What we do know, however, is ALK-Phos does tend to be a surrogate marker for survival, and those that have a lower ALK-Phos had a decreased progression to cirrhosis and decreased PSC-related clinical events. Small duct PSC is rare. This is normal cholangiogram, but a biopsy showing PSC. This can progress with time to classic PSC and up to a fourth over 5 to 14 years. And it's thought that there is a decreased risk of colon cancer as well as a decreased risk of cholangiocarcinoma. And we don't know if small duct PSC is really a separate entity versus just really earlier mild PSC. Females with PSC have better outcomes, a lower risk of malignancy. And pediatric PSC tends to be also different. It tends to be male predominant, a very strong association with IBD, and a much higher frequency of overlap with autoimmune hepatitis. And actually, it's those patients that have overlap that actually have an even decreased risk of death compared to those with PSC alone. And you can see here that those that are diagnosed young, less than 20, compared to those that were diagnosed older at greater than 60, have a 2.5 times longer transplant-free survival and a 17 times lower rate of cholangio. So treatment right now, there's still no FDA drugs that have been approved specifically for the treatment of PSC. Treatment still is directed at complication and symptoms if and when they occur. As we mentioned, therapy of IBD has little effect on PSC and vice versa. It's important to monitor for malignancies, think about liver transplant. And of course, I'm biased, but I think we should really be thinking about clinical trials for any patient that has PSC so that we really can kind of find a drug and advance the field. Malignancy, cholangiocarcinoma can occur at any time. Overall, there's about a 20% lifetime risk. These patients are at risk for colon cancer, increased risk for pancreatic cancer, and those that have cirrhosis, they're increased for hepatocellular carcinoma, and they also have a higher risk of gallbladder cancer. Looking at cholangiocarcinoma, we do look at CA19-9s, but the greatest risk for cholangiocarcinoma is looking at a combination of a CA19-9 greater than 130 and the presence of polysomy. So you can see here this curve over here that those that have polysomy and a high CA19-9 have up to 100% risk of developing cholangio within 3 years. Screening has actually not been shown to be effective. I think it makes us feel better, and so we do recommend getting MRCPs and CA19-9s at least yearly. And then again, liver transplantation can be possible in those that have cholangiocarcinoma, but it's really select few. I will encourage patients or you that are seeing someone that might have a cholangio not to send for a percutaneous liver biopsy, as that will rule them out for liver transplantation. Again, I think we're all familiar with this, just showing the much higher rate of colon cancer in patients with PSC and IBD compared to those with IBD alone. Other disease-related complications include infections, strictures, stones, increased risk of osteoporosis. They can develop hyperlipidemia, fat-soluble deficiencies, malabsorption, and fatigue. And although rare, cirrhosis also can occur. So in terms of how we just survey them in general, imaging every 6 to 12 months for both cholangiocarcinoma and HCC. Consider getting a CA19-9. If someone has a gallbladder polyp that's greater than 8 millimeters and does not have cirrhosis, consider preemptive cholecystectomy and annual colonoscopies of IBD. Once these patients do develop jaundice like PBC, this is when I usually screen for your fat-soluble vitamin deficiencies. Get a baseline DEXA. I will say that some insurance companies will fight you for a baseline DEXA, both in PSC and PBC. These patients should be vaccinated, like all chronic liver disease patients, for Hep A and Hep B. Low threshold to repeat a colonoscopy in patients with new diarrhea. Annual ultrasounds with low threshold for chole. If on initial colonoscopy they do not have IBD, we recommended considering repeat colonoscopy every 5 years. So what about actual medications? Again, there is no FDA-approved treatment. Low-dose urso, the liver tests improved, but there really have been no changes in survival. Looking at high-dose urso, which is 25 to 30 mg per kg per day, this study was actually terminated early due to death and variceal bleeding. What we don't know is what about this intermediate dose urso, which is 17 to 23 mg per kg per day. Liver tests do improve on this intermediate dose, and there does tend to be a trend toward improved survival. So in patients with PSC that does have sustained elevation in ALK Phos, we can consider using ursodiol and reevaluate in 6 months, but this really should be a case-by-case basis. This is looking at those that were on urso that responded. And this is this black line right here. They have a much better survival rate than those that do not respond. So what about drugs that are being looked at? There have been so many trials looking at many different medications that basically work on all kind of 4 of those arms of that pathophys slide that we did early. And so far, results really have been mixed. So vancomycin, most of the data comes from patients that have IBD. But in a recent study, this is probably the largest study on the right, there really was no benefit, no difference in survival in those that are on vanco and those that are not. So right now, the guidance does not recommend using vanco outside of a clinical trial. There is a clinical trial, but it's been very difficult to recruit people because you can get vanco just without being on a trial. Nor urso is not available in the United States. A lot of people that have PSC have asked us about it. It's a C23 homolog of urso that induces a bicarb-rich cholestasis, and it's well tolerated, and it does seem to decrease your alk phos. Looking at itching, looking at that fibrates now for itch, that Fitch study that I mentioned before, looking at the patients with PSC, those that were on bezafibrate had a 41% decrease in itching score compared to only 11% on placebo. And if you look at EASL practice guidelines, it actually is their first-line treatment of cholestatic itch. Similar to PBC, we're also looking at the volixibat in patients with PSC. Couple other sides just to know about. There was a study that came out a couple of years ago from Sweden. It was a retrospective study, and those with PSC that were on statins had a decreased all-cause mortality rate, decreased liver transplant rate, and decreased adverse liver event in total. And there is currently a phase 3 study going on in Sweden, excuse me. And finally, there is berberine. Berberine is a compound, an herb that has been used in China for many years. And berberine does have antimicrobial, anti-cholestatic, anti-inflammatory, anti-fibrotic effects as well. So there was a study where they combined berberine and ursodiol. And just looking here, again, this is just a very small study, but you can see that patients that were on the combination berberine and urso compared to placebo had decrease in their alk phos. At one time, this was short-tracked to be approved by the FDA, but I have not heard really anything in a while about that. So I think in summary, PBC is an autoimmune disease resulting from genetic factors and environmental triggers. It progresses slowly, but progression can vary. Alk phos and bilirubin have been identified as biomarkers for therapeutic response, but again, optimal response cutoffs vary. And while treatment with urso is effective for 60 to 70% of patients, a considerable number may still have elevated alk phos and or bilirubin. As of today, we have a beta-cholic acid and elfibranor as second-line therapies. Next month, we'll hopefully also have seladelpar, and I think bezafibrate and fenofibrate are promising drugs as well. In terms of PSC, again, it has no established therapy. Response to urso does establish prognosis with, again, those that have normalization of alk phos tend to do better. High-dose urso for sure should be avoided. Clinical trials should be thought for any patient that has PSC, liver transplant in some, and then remember that there is a higher risk of gallbladder, bile duct, and colon cancer in these patients, and so it's important to survey them for these malignancies. So thank you. I am happy to take questions. And while you're thinking about your questions, just want to alert everyone that we will be having our annual Rocky Mountain Highlights in Gastro and Hepatology on August 10th here at Ansute. I don't know if there is a virtual option. So looking at some questions. Does anyone have any questions? I don't think there are any. Vash, am I missing any? One. Wow. Okay. Well, if there are no questions, then I will conclude. Thank you all for attending, and hope to see you at the next webinar, which is going to be on alcohol-associated liver disease. My partner, Dr. Norvell, will be presenting on September 18th. And again, remember the Rocky Mountain highlights on August 10th. Thank you and have a good day.